So this is kind of a sobering statistic that if you were to accurately count, and it's hard to count, all the number of deaths from child abuse, it turns out that that actually exceeds all of those from pediatric tumors. And when you think about the donation efforts and fundraiser drives for any individual tumor, and yet there isn't really anything equivalent for child abuse, which is something that really requires you to be on your game to detect. It's something that I, as a pediatric radiologist, think is the most important thing that I do. Given this statistic, given that I might be the only person who detects this finding when all the other signs are misleading and the clinicians may not exactly be sure of what's going on with the patient. Now, the good news is the rates of abuse do decrease with age, but they don't go away entirely. So you can't just assume that because it's not a baby that this is no longer abuse. So what is your job as a radiologist? First of all, obviously find the fracture. The fracture is really going to be the thing that we talk about in this lecture. You want to be able to estimate the age of the fracture to determine, are these all injuries occurring at the same time, or perhaps these are healing injuries? And then really the crux of this lecture is this an injury that is specific for abuse, or is it something that could have happened by accident? Okay, so how do we actually do the survey to rule out non-accidental trauma or abuse? The American College of Radiology has a specific protocol that basically says you want to x-ray everything in frontal projection at least once. You can always repeat something if you're unsure, or maybe there's a wristband that's covering up what you need to see. You will also do a lateral view for the skull and the entire spine. You will also do oblique views for the ribs. Now, there's some additional recommendations to improve your ability to detect fractures. One is to use mammography plates because they have such a high resolution, and because your patients are so small, it's going to add to your ability to detect the very subtle non-displaced fractures or very subtle periosteal reaction. But not all facilities will have access to mammography plates, which often come with their own quality control requirements. So it's not a trivial thing to use these, but it does help if you can do it. It's important that you get the study done right the first time, which means try to do it during working hours if at all possible, and having the attending radiologist there to look at the pictures and make sure that nothing's missing, that nothing needs to be repeated, so that there isn't any uncertainty introduced that might later be taken advantage of in the court of law by the defendant attorney. And then, as I had alluded to earlier, having one of your colleagues also review the study to look for fractures will help identify additional injuries that one person on their own might miss. And again, if all it comes down to is one injury, you want to find it now. You want to find it before more serious injuries occur. And then some additional general tips. You can do a follow-up survey if, let's say the team is very concerned, but you didn't find anything, so it's a normal exam, but there's a high suspicion, or there might be an indeterminate finding, which can be very common in peds where developmental normal variants can look like injury, and you're just not sure, you want to play it safe. It's okay to do a follow-up survey. Okay, what about some other tests? So we're going to talk individually about these as well. So bone scintigraphy might reveal an injury that you missed on just the x-ray survey. So if your suspicion is high and you don't want to wait and do a follow-up, you can also consider a bone scintigraphy. Now, it's going to be better for rib fractures, so that's good, but it's not going to be as good as for classic metaphyseal lesions and skull fractures, which, as we'll see, are types of injuries that can be very suspicious for abuse. So it's not a perfect test, but it's an option to consider. What about CT? So CT is great for head injury. It's excellent for skull fractures. We're not talking about that today. So what about in the context of rib fractures or extremity fractures? CT should, in that case, only be reserved for equivocal cases where you're not sure if there's an injury and you just want another way to look at it. And again, you don't want to wait and just do the follow-up survey. So again, CT, apart from head injury, is really going to be only reserved for equivocal body injury cases. So here there's 2 fractures, and you can imagine how if they're non-displaced, it could be tough to potentially see on an X-ray. And then lastly, MRI. Again, we're not talking about brain injury, for which MRI is very important. In the body and extremity imaging, conceivably you could use it for soft tissue evaluation, but like in this example here, the abnormality is actually much easier to see on the plain radiograph as a classic metaphyseal lesion, which we will talk about in just a moment. That is the end of the first segment. We are now going to move on to the next segment.